Leah Owen, and I work at the Moran Eye Center in Salt Lake City, Utah. I am a clinician scientist. I have trained clinically as a pediatric ophthalmologist. I also have a background in molecular biology. I did a PhD training in the study of cancer biology, specifically Ewing sarcoma, pediatric sarcoma, but then transitioned clinically to an ophthalmology focus, and then as well transitioned my research to looking at mechanisms of vascular development and in particular neovascular disease of the eye. My background in cancer biology kind of introduced me to translational research and the importance of starting, in my view, in the human condition to characterize our most basic understandings of the pathophysiology of disease in a human model, because ultimately when we intervene therapeutically, our therapeutics have to be relevant to the human molecular processes that are resulting in disease. And starting in the human disease model is the fastest way to understand those disease processes and then translate our molecular techniques, our molecular understandings to effective therapeutics. And this is much easier to achieve, I think, in the cancer field because cancers are often removed. So we can have easy access to those primary human disease tissues. And then when I transitioned my work to the eye and understanding aberrant neovascularization in the eye and in the retina, in particular, that became a more challenging prospect because I wanted to study the disease process in the primary disease tissue, the eye, the retina, as I had done in my cancer background, but you cannot access that tissue quite so easily. And we don't do macular biopsies very often. And so this was kind of a problem that I wanted to understand how we could address more effectively, because many of our discoveries in macular degeneration have relied upon access to systemic human tissues like blood and even sometimes skin biopsies and things like that, which are more easily accessible. And certainly some of our genetic understandings and things rely upon germline DNA, and that presumably is the same in every cell type. But then there are also important things like local disease mechanisms where there's a microenvironment that may have different modifiable DNA changes like epigenetic changes, or there may be specific molecular pathways that are only relevant to that local disease process that we can't understand when we look at systemic changes. And so to better address that deficiency and kind of understand how what we were testing systemically could relate to the actual local disease process, I partnered with a colleague, Margaret DeAngelis, at the Moran Eye Center as well, to build a repository of human eye tissue that we could then start asking some of these questions using. But there are some important things, considerations, to make sure that the rigor of our analysis is intact and therefore our translational ability. And so some of those things that we've been addressing, number one, death to preservation time is really critical because some of these mechanisms may change post-mortem. And so we certainly don't want to be measuring artifactual changes that are just relative to the postmortem status of the eye. So we instituted a very rigorous less than 6 hour postmortem time to preservation for collection of our postmortem tissue. And then we also instituted a very rigorous and highly reproducible and standardized method by which each eye would be processed within that time frame. And so that we could easily measure the same things in multiple eyes, understanding that they were processed within the exact time parameters post-mortem, and that they were processed in the exact same manner each time within that time frame. And this includes, for highest translational value, the way we process the eyes includes techniques that are used clinically. So these are things like, obviously, color fundus photography, something that is widely used clinically, but then we also incorporated OCT imaging for better understanding of the retinal structures. And certainly this is used clinically as well in diagnosis of age-related macular degeneration. And so we wanted to really, as best we could, recapitulate the exact scenario that a patient would undergo in the clinic if they were being diagnosed for an eye condition, in particular macular degeneration. And then, of course, we also obtain systemic samples from each donor patient, namely peripheral blood. And then we pair that with their eye imaging, as well as then processed retinal samples that include a macular punch, as well as peripheral tissue punch. And these specimens are preserved in such a way that we are then able to ask questions about their RNA expression, as well as their DNA expression, and modifications, and protein expression. And so in addition, what we've done to really make our system very highly translational to human diagnosis of age-related macular degeneration is that we then analyze all the images we've obtained using a very clinically relevant scheme. And the analysis is done by 4 independent clinical specialists who diagnose macular degeneration and treat patients with macular degeneration daily. So they apply their clinical understanding of the disease to our postmortem donor eye images. And they do it in the same way they would do if they were seeing the patient in clinic. Namely, they look at the color fundus photos, they assess from those if macular degeneration is present, and if so, what AREDS classification they would apply to the patient, and how they would classify the disease. So we use a very relevant clinical grading score. Now, the AREDS classification, when it was developed, was based solely on color images. But we have taken that a step further and we've adopted a name of a Utah grading classification, but where we incorporate the OCT findings with the color images, but yet assign an AREDS classification score to the disease. And we feel like that helps us resolve some questions about the presence or absence of subretinal fluid or scarring, which can be indicative of a choroidal neovascular membrane. And so it can, when we see those findings suggested on the color fundus images, because these are postmortem images, sometimes the coloration of the retina can be slightly different than what we would see clinically in a patient who's alive. And so adding the OCT, as is now done in clinical practice, to help resolve some of these structural changes in the retina that occur with age-related macular degeneration, and be more precise about our diagnosis, is really very helpful in ensuring that we have an appropriate diagnosis for a postmortem patient, and then also helps us assign a clinical score that is relevant to how patients are scored clinically when they're living. And so this just increases both the rigor and reproducibility of our analysis technique, but also the translational applications. So these images are individually scored by each of our 4 clinicians, and then any images that have a discordant score, there's a discussion between 2 to 3 of us that we kind of go through all of the images and come to a consensus. We also incorporate available medical records when appropriate, and they're not available on every patient. Our catchment area is quite large. We work with our local Utah Lions Eye Bank, and so we don't just have donors participate who have been seen at our eye center, but they could have been seen in the community or even in a different part of the state. And so because of that, we don't have medical records and ophthalmic records in particular on every patient. When we do, the level of clinical evaluation can vary. It could be that they were evaluated just for their cataracts by an optometrist, and that their posterior pole or their macula was not evaluated, or it could be that they were followed for macular degeneration. And so we take into account the different level of clinical information that's available in the medical records, and then we kind of assimilate that information into our diagnostic process when we're deliberating as a team on what the diagnosis of the eye is. Yes, that's a great question. So when a donor eye comes in, we have kind of minimal basic information that's provided by the family. So sometimes the family's aware of eye diagnoses and other times they're not. But then we request medical records through our Utah Lions Eye Bank. So we partner with them. We also have an approved IRB to do this with the highest level of oversight, but we request formal medical records, and within those medical records we find a variety of ophthalmic records. They could be evaluated in an ongoing fashion by an ophthalmologist for a chronic ocular condition including macular degeneration, or they could be seen periodically for mild cataracts or not at all. And so the ophthalmic records kind of have varying levels of pertinence to the macula and the retinal health. And so we take that into account when we include them in our analysis process. Number one, we've been able to show in over 600 eyes that we've collected since late 2013, early 2014, that we have a high level of reproducibility of our ability to diagnose properly AMD. And so there are several ways you could look at how reliable our diagnosis is. And one way is if the patient had documented age-related macular degeneration that was being followed by a medical doctor. That is a fairly certain gold standard of the fact that they, in truth, did have macular degeneration. And so we found a very high concordance in our physician and clinician's ability to diagnose age-related macular degeneration in the postmortem eyes and have that correlate with a diagnosis of macular degeneration when the patient was living, which is something they only can find out after their diagnosis using our postmortem analysis techniques. So we've been able to demonstrate that our database and our system of analysis has reproducibility and applicability to the clinical condition that the patient in fact has. Because if you don't have a good correlation between the ocular phenotype in your tissue, it doesn't really matter. You can do a lot of analyses on the ocular tissue, but you don't know what those results actually tell you if you don't know what disease process the patient had or didn't have. So that's kind of the first and very fundamental step that we wanted to achieve to say this model is reproducible and applicable to the human disease process. So we've been able to do that, and that publication will be coming out soon. And then we're moving toward looking at the individual tissues. And we've started to do that looking at the retina, looking at the RPE, looking at the choroid in the macula in diseased individuals or people with macular degeneration and people without. And we've looked at that in people with all forms of macular degeneration, the earlier forms, as well as the late and more severe forms, to try and understand, number one, what are the fundamental molecular pathophysiologies that are driving these disease states? Are they the same or different depending on what phenotype of disease you actually have? You know, because the majority of patients who start with some form of early macular degeneration do not progress to the more severe forms. And so are these different disease entities at the local tissue level, or are they a spectrum of molecular progression, and where can we intervene? So that's where we're starting to go, and we've started to look at a variety of things in these individual tissues, including local expression, both at the RNA level and the protein level, and also how that expression might be modulated relative to not just genotype, but also modifiable DNA changes like epigenetic regulation. And we know that that's different tissue to tissue. I mean, that's been substantiated not just in eye research, but in other disease pathophysiologies of disease. And so I think that's going to be very exciting as we kind of build this work. And so our paper that will be coming out soon, just documenting this is our procedure, this is how we do it, you know, et cetera, this is our reproducibility relative to the clinician team evaluation approach, as well as medical records from the patient. The purpose of that paper was just to help others implement this grading scheme and this technique. And so we certainly hope that, our hope would be that we have created a system that is going to be able to be used widely when people can collaborate with their local eye banks, as we've been so fortunate to do, and lead to a reproducible approach to studying these local disease mechanisms. That's our hope.